Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today I'm delighted to be joined by Dr. Craig Joseph. He's the Chief Medical Officer for Avaap. He's also the best looking physician that I know on this planet. For those of you that don't know him, you should Google him and look him up. Craig, thanks for joining me today.
Well, thank you, Nick. And I think people will be disappointed when they Google, but really it's all in the eyes of the beholder. And so I do appreciate that comment. And I do deny that I asked you to say it.
So Craig and I did this last month. We're trying to start a regular event, sort of talking about the latest and greatest in terms of news. We're coming up to the end of the month, and there's been a lot of news. Few topics on the list. Let's kick off. I think, Craig, you wanted to talk a little bit about open notes. For those of you listening, maybe it's worth just briefly sharing what they are and what your thoughts are.
Yeah, so open notes is a movement, really. A lot of people confuse it with a functionality or technology, but it's really a movement to share the notes that physicians take about our patients with the patients themselves. Now, that's always been for forever, really. You've had access to your notes, but you never looked at them. You could have always gone into the hospital's medical records department and pay typically a lot of money to get a copy of your chart. You could also go to your doctor's office and say, I'm moving to a different doctor and I need to take a copy of my chart. And you could see the notes there. Often they were cryptic, they were handwritten, so they were messy. You couldn't read them. And even if you could read them, they'd have abbreviations that didn't make any sense. So this
and if you buy Samuel Shem's view of the world, sometimes a little bit insulting too, right?
Often in medicine, I think you know, and your listeners may or may not know, we tend to use jargon that may not be pejorative from in the way we intend it, but certainly
comes across that way, right?
Comes across that way. Sure. We say patients who don't follow our instructions, we call them non-compliant.
Right.
Now, it might be that they're just smarter than we are and decided that our advice was not good. We will note them as being non-compliant. And then sometimes we use terms like obese. And we might mean that in a academic, scientific way, meaning here's what your ideal body weight is for your height and gender. And you're, if you're more than X percentage above that, you're overweight. And if you're more than that, then you're obese. And so we use these terms that sometimes people find offensive, which actually is a reason why some physicians are not supportive of this open notes movement. So
yeah, that was exactly one of the points I was going to make. Not everybody is for part of that reason, because it's this sort of secret, not secret in a bad way, but a quick fire way of communicating things that are clinically relevant.
Well, it's I think some of us who were alive and watched Seinfeld back in the day, there was an episode where Julia LouieDreyfus was trying to get a copy of some of her notes, and she was getting blackballed by physicians, and she had to go from physician to physician because they heard that she was trying to find out what we were writing about her, and no one wanted to see her or deal with her.
So just to be clear, that means this issue has been going on for a long time,
and that was long before we had patient portal. So really, it's kind of come to a head. And when I have this conversation with physicians who say, I don't want this, I don't want to just share my notes with patients. I say, well, they've always had access to them, right? But we all know that almost no one is interested in doing that. And almost no one actually goes and looks at the note. However, with this movement, now we have technology to be able to share things with patients from our legal medical record, our electronic health record, via the internet. And so via patient portals, we call them, where patients can log in. Everyone's kind of accustomed to looking up their lab results nowadays, but the ability to kind of share what your doctor wrote about you last week or yesterday or this morning is pretty amazing. And some physicians have kind of changed the way that they document certain things.
In a good way or a bad way? I mean,
Well, I think the ones who are trying to be sensitive to the point that you brought up about using language that may not be pejorative or negative to us, but might be perceived that way. So kind of not saying non-compliant, saying that the patient chose not to take my advice with respect to exercise, or those kinds of things.
but I mean, on that point, I think it's worth pointing out. So I remember reading vividly a paper that talked about this whole issue of labeling people obese and overweight and so forth. And what I understood from it was, if you don't actually label somebody appropriately in a clinical sense, and I get your point about pejorative, but if you don't state it, people continue to sort of internally deny it. But when your physician says you are obese and you have a BMI, and that actually is part of the pathway to an improvement. So if we're not, we're failing our patients, right?
I am certainly not a believer in the need to significantly change the way you document. Now, there are those that do. I think you're right. Like, this is the chief reason I've created this document, this progress note, this history and physical, is to communicate with other clinicians. That's what I would argue. Now, in the United States, we use that same document for many other things. We use it for billing. We use it to decrease our risk for malpractice. We use it for lots of different reasons, but I don't think the chief reason should be to communicate to your patient. So for doctors who say to me, well, am I not supposed to use jargon anymore? Am I not supposed to say hypertension? Do I have to say high blood pressure, which might have some different meaning? And my answer to them is no. You write your note the way you want to write your note. There might be terms that you want to start to avoid if you think they might be misinterpreted, or you might say, when I say this, I don't want you to think of it in the way that normal humans would use that word. I want you to think of it the way we in medicine use the word. But I think it's, as a patient who goes to doctors who have adopted open notes, I immediately go and look at my note. Now, again, I'm a physician, so I have a little more insight than most, just because of my training and experience. But I've certainly heard, and there are now studies to support that patients who read the notes are more involved in their care, because oftentimes what we say when we're giving advice is forgotten. Yep. Or the specifics of it are not remembered as clearly, and so having that be available, forever online, as long as I have a username and password, I can go and see those notes. It's, very helpful. And further, sometimes when you go to a doctor who may not have an electronic health record or doesn't have access to your particular version, for the ability for the patient to say, well, I think you said something about starting some medicine, to a specialist. But the ability to kind of pull up a note on your phone to say, oh, well, give me 1 minute. I can actually pull up that note. And again, ideally, the doctor would have access to that. But if he or she doesn't, that you're kind of making interoperability yourself there. So it's just, I think it's a great thing, and I'm very supportive. And I would ask, if your doctor uses an electronic health record and that there's a patient portal, and if you're not having access to your notes, I would ask your doctor, why is that? And I think the government's going to help push this, because there's this new concept. I shouldn't say new, but it's becoming revived, right? It's called data blocking. And I think the term initially was referring to one EHR not sharing information with another EHR, or one hospital thinking there's a competitive difference and they're not sharing information. Well, we want to make it difficult for you to go to hospital B, so please keep coming to hospital A. But now there's some people, I'm not sure if they're right, but there are some people who are making an argument that, hey, if you have the ability to let me see my progress notes and you're not sharing those with me, aren't you, doctor, kind of data blocking me?
Yeah.
Why are you making it? Yeah.
It's an economic thing, and that's even with hospitals that had the same EMR. It wasn't even a technical challenge. I will say, I mean, I've been collecting my medical notes, and like you, I come at it with a slightly different viewpoint, but I have, in part because I've traveled internationally, I've got medical notes scattered to the four corners of the globe, but I would always insist on those, and I captured them in paper form. I finally scanned them all, and for me, it was the sort of the only source of truth ultimately, because the idea that anybody from another country would get access to the relevant information always just seemed wrong. But I think your point about terminology is important. I hear a little bit of pushback from some patient advocates saying healthcare literacy is an issue, but at the same time the access to information in this day and age is such that you find those terms. The first thing you do is you hit Google, right? And all right, it's an imperfect tool, but it's pretty good. I mean, I've not had sort of major challenges with some of that. So I think that's right. I mean, it's on the pathway to sort of engagement. And I agree with you. I think the sort of overall experience is very much positive from an engagement standpoint, which is one of the best drugs that we have, patient engagement. And ultimately for a positive experience, because you start to understand your physician's thinking, and if you disagree with something or you find something that you dislike, I mean, I think that's an important issue to discuss with them, because why did they put that, and why do I disagree with it? You're assessing me in a way that maybe I disagree with. So I like it. I mean, I think it's it's an essential part of our future. I'm just disappointed we don't have more of it and more engagement. But I'm sure that more unlocking of that information is going to be helpful. So moving on, I think I want to sort of capture a few of the things that have gone on. And of course, the major piece of news, or certainly the one from my feed and things that have been going on, relates to this Nightingale, which was named after good old Florence project and I didn't know that's why it was named that way. It didn't even occur to me, ironically, but where Ascension and Google are working together to share patient records, and suddenly there was an awareness of this issue, and everybody got very worked up about it. My initial reaction was, well, it's business as usual. This is not unseen in other instances. We see plenty of organizations that share data and then try and use that data. And in this particular instance, as I understood the project, it was about providing relevant information at the point of care to physicians in a way that they could actually use it, which, I'm pretty sure most physicians would hear, and even patients would say, well, that's useful. I want some of that. But, big pushback. What were your thoughts?
Well, I agree with you in terms of my initial thoughts were, so what? And I think that's, I have a pretty cynical take on privacy, in that I think most of us don't have it, and we often give it up online. So
freely
for probably minimal benefit.
Yep.
Often with us knowing exactly what we're doing, and sometimes not. But you're right. They had signed Google with Ascension. We should point out Ascension is one of the largest hospital systems in the United States. Google had signed a BAA, a business agreement, where they say that they won't share that information. They'll use that information only for patient care. And so what that means is Google, not being a lawyer, but as it's been explained to me, Google's not allowed to take any of those pieces of information and use it for advertising, use it for anything really, except to make help work on a product that they're creating to help, as you mentioned, make predictions. So, hey, we think this patient is likely to be readmitted to the hospital because a lot of other patients that are just like this patient have been readmitted within the 2 to 4 weeks after discharge. That's very helpful information for physicians to know, because that might change their course or make more aggressive follow-up. If that's a patient who doesn't come to the doctor's office for follow-up, you're gonna want to send a Lyft or an Uber out to pick up that patient if that's the problem.
Exactly.
Right? So there are things you can do to impact that. Also, there, as you mentioned, in the electronic health record or the electronic medical record, being trying to surface information. So that's back when I started in this healthcare IT game 15 years ago or so, people wanted information. We need more information. We need all the information. Give us the information. And now, actually not just now, but probably the last 5 years, what I've heard from a lot of physicians is stop giving me all this information, right? Hey,
Right.
I wanted more information, but I wasn't exactly clear on what I said or what I was thinking that I needed. So now we're dying in a sea of information. I have access to every hospital system you've ever been to. I have access to every note, every hemoglobin that's ever been drawn, yet I don't really know what's important. And if something or someone can help surface that to me and say, hey, you might be interested in knowing that, well, we don't have an echocardiogram for this patient. We do find the word echocardiogram in these 3 notes. And using maybe natural language understanding, it's not so helpful to me to find an ER note that says there is no echocardiogram. That's not helpful.
Right.
So you're not really just looking for the word, you're actually looking for context and words around the word to say,
Right.
oh, the patient had an echo which the cardiologist reports as negative. Ooh, that's very helpful. And so, and if Google or anyone else can kind of use logic and experience to say, hey, other patients like this patient, the doctor was interested in electrolytes and an echocardiogram. Let's look for that. Let's not make the doctor ask us for it. Let's just surface it.
Right.
And Google's well positioned, as is Ascension, because Google doesn't. My experience with Google, I worked for a company that was relatively small, 4,000 or 5,000 people. We had Google to help organize all of our internal information. It was horrible. It didn't help me when I was searching for something. It didn't serve up anything. And it's not that the Google algorithms are dumb. It's just that there wasn't enough data, and so it couldn't come up with those predictions, which real Google does. When I start typing some letters in the Google search box and on the internet, it's uncanny often that it figures out exactly what I'm asking, and I get different results than you get. So if we can, if Google can get access to data like that, and then make some suggestions like, hey, patients like this, often the doctors are looking for these things, or even better, when you look up these things or see a patient like this, you're interested in these aspects. So again, if I'm an endocrinologist, I'm interested in very different things when I see this patient than as a cardiologist, than as a primary care doctor. And so Google has to be, I'm putting that word Google in there, but that's really what I think they're working on with Ascension, to see if they can sit on top of the electronic health record. Google does not make an electronic health record. I don't think they ever will. But if they can get access to all the data, both the discrete information like lab results and vital signs, and the text of notes, they have proven that they can do amazing things with that. And so I think that's what they were trying. That's what they're shooting for. That's what they continue to shoot for. But I understand how people freaked out. It's Google. And
there's a lack of trust, and we have to assume that BAA agreement, which if you believe the letter of that and the spirit of it, then they're limited, and the positive impact is, as you describe, it's this sort of value add, and part of me thinks, gosh, Google could even apply all of the search information that we've used, and that whole SDOH that everybody's talking about, and tie all of this with the data aggregation for the benefit of the patient. So going that way. Now the negative of that is to say, hey, let's tie all this other data and go, oh my goodness, I see that this person is being treated for diabetes, but they're still buying all of these candy bars.
Yes.
So it's some of it's trust, and I think part of what everyone is looking for is some affirmation that we can trust that BAA agreement, and this is going to be used for good as opposed to bad, which I interpret bad at an individual level, that says, hey, my premium rates just went up because you applied some predictive analytics on me and think that I'm going to be unhealthy just based on some buying habits, but I'm actually buying for my children or whatever it happens to me. So
correct.
I think that's
makes sense.
Unresolved at this point, but I'm with you. My glass, as I always say, is half full of whiskey and half full of air. I consider it full. And in this particular instance, I'm hoping that people do the right thing. And Google is the best instance in my mind of solving the problem. It's never a data problem. It's always a filter problem. And they are a great filter in this whole process to get you to what you need.
It's absolutely true. And again, I don't find very many physicians who say, please give me more information so that I can spend 2 hours looking it up, right? They do want some magical, algorithm to the word I like is to surface, show me stuff that I'm probably interested in before I know that I'm interested in it. And then you'll have a friend forever. And so if that all sits in the Ascension system and this magic is happening there and not going up to Google servers, then I agree. I think it's the risk is small and the benefits are mighty. And this does happen. Every hospital has these BAAs, these agreements, these business agreements.
Right, standard fare. It was the way that we developed all of our nuance technology for transcription. We took all of that information to allow us to transcribe and then connect the transcription to the voice. And that was how we created the technology. It was part of the process.
Yep. And the vast majority, almost everyone does the right thing. There's no intention to not do the right thing. Mostly the problems that we've seen have been when our security incidents happen. Hey, we took your data, we put it on our own servers. We weren't going to sell it or anything, but now someone broke through because we didn't do an upgrade or an update, and now the data is somehow on the internet, and that's bad.
Right.
So, and I think I read an article that said Ascension was so worried, or appropriately so, that they had a compliance officer in every meeting with Google just to make sure that no one was talking about doing something that might be outside the boundaries of that BAA. So, again, I think they're trying to do the right thing, but people are appropriately concerned that it's not, that they'll, like you said, Google will find out that I'm buying candy bars and now my insurance rates will go up, and that would be an inappropriate use, and Google should never have that data outside of the Ascension system.
Let's not turn Google into Minority Reporting.
Not yet. And we're picking on Google. It's just
it's any of the data service providers.
Let's talk about our credit information and. That's when I went downhill in terms of my own.
When your credit went downhill?
Well, no, that's a different story, Dr. Nick. No, when a credit reporting agency who I never gave permission to collect data on me, collected data on me, and then didn't do a good job with security, and all that information went out onto the black web, and so I don't have. I have no expectation of privacy with regards to my social security number or many other things because it's out there and I can't get it back. And so, those are bad actors, in my opinion.
It's misuse of data. In fact, there was the most recent one this past week was, I believe, the largest by far in terms of data. I think it was PDL was the name of the company.
Yep.
Most folks won't even know that name. In fact, many of the security researchers that have been commenting are going, who the hell are these folks? And yet it was gargantuan. If you haven't been touched by this, I don't think you exist on this planet, or at least not in terms of technology.
Yep. And you can, for anyone that's geeky and interested, there are probably more than one, but there's at least one website where you can go and put your email address in that you commonly use for accounts.
Yes, have I been pawned?
That's
exactly. Haveibeenpawned.com.
Yep. That's exactly right. And so they don't charge you anything. And then whenever they find your email address, they say, hey, you might want to know that. And so that's how I found out about this PDL thing. I got an email, I think 2 days ago. Hey, some of your information's there. And again, I'm at the point now, I'm like, yeah, whatever.
So for those of you that haven't, you should go to that website. Have I been pawned is PWNED.com. It's run by Troy Hunt. He was a previous guest on this radio show, done an outstanding job of sort of aggregating all this data and doing a really good job in creating a resource for the good people to access, but not for the bad people. So you can't do a reverse lookup and say, hey, let me go have all of this data. It's actually done a really clever job of that, which, I admire. Unfortunately, we have run out of time, as usual. We only got a couple of topics in, but always a pleasure to catch up with you, and looking forward to sort of wrapping up the year. And I think we'll go for some predictions for the year 2020, which is a big one, right, for next month.
Is there money riding on this? Are you talking about
if
wagers?
You can find me in 10 years time to say, yeah, you were right or you were wrong. Oh, well, I guess if we're talking short term, yeah, we'll put a wager on it for the end of 2020.
It's only fun if there's a wager involved. It might involve scotch.
Oh, it always involves scotch with me, whether it's supposed to be or not. So
Excellent.
All right.
I'll work hard on those predictions then.
Yeah. So you're going to be studying the whole month long, as I know you well for this.
Cancel my plans for December at this point.
All right. Craig, thanks for joining me today.
It's my pleasure. Thanks, Nick.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.